Welcome to this segment on the cognitive and mood aspects of Parkinson's, also known as the 3 M's in Parkinson's: mind, mood, and memory. The symptoms on the left-hand side of this slide, impulsivity, psychosis, and confusion, are generally side effects of medication, but they could be symptoms of Parkinson's. If they come on suddenly, they are likely related to medication. The symptoms on the right, anxiety, apathy, depression, cognitive changes, and dementia, are symptoms of Parkinson's. In the last 5 years, serious issues have emerged which include gambling, shopping, hypersexuality, excessive internet use, and excessive eating. These are pathological behaviors characterized by failure to resist an impulse to perform acts. These symptoms may result from several Parkinson's medications. However, they are more commonly a side effect of agonist therapy. The agonists have additional side effects of excessive daytime sleepiness and risk-taking behavior. These behaviors can have a big impact on family and friends and can damage relationships and erode the support network that is so important for people with Parkinson's. Impulse behaviors may result in significant distress, marital conflicts, financial difficulties, and even legal procedures. Often these issues are not raised with healthcare professionals because of their personal nature and the social stigma attached to them. It's important to ask directly if the patient is having difficulty with any of these behaviors. In long-term care, it's not unusual to see sexually inappropriate behavior that could be due to impulsivity or related to dementia disinhibition. Psychosis is a loss of contact with reality, and the symptoms include hallucinations and delusions. Some people with Parkinson's don't find mild hallucinations frightening if they recognize them as unreal, and some people choose to live with them if their medication is providing them with good mobility. Hallucinations in Parkinson's are almost exclusively visual and not auditory, and people often report seeing people when none are there. Delusions are fixed, irrational beliefs, and they are paranoid when the person believes that someone intends to harm them. Paranoid delusions make treatment and food delivery difficult, and these symptoms are very distressing for caregivers who should be given support. Confusion is the sudden onset of disoriented and muddled thinking, and it may or may not be accompanied by psychosis. Confusion can be caused by medication, dehydration, overheating, and constipation, or by a secondary illness such as acute pneumonia or a urinary tract infection. In long-term care, try to ensure that the patient does not overheat and is sufficiently hydrated. Anxiety is a fairly common symptom of Parkinson's, and it has a major impact on other symptoms. It worsens tremor, dyskinesia, and gait freezing. Anxiety is a contributing factor to depression and insomnia. It may be related to fear of being unable to function, embarrassment due to people noticing the symptoms of Parkinson's, and off-state anxiety, possibly due to under-medication. Untreated anxiety is challenging for people with Parkinson's and taxing on relationships needed to support the person living with Parkinson's. Treatment is important and may include adjusting Parkinson's medication to reduce off times, improving sleep quality, increasing physical activity, prescribing SSRIs or benzodiazepines, or referral to a psychiatrist or neuropsychiatrist. Apathy is a reduced interest and participation in activities. It's important to note that apathy is more likely to be a result of the disease process, a pathological change, rather than a psychological reaction to Parkinson's. Apathy involves reduced interest and participation in activities and lack of concern for self and others. It's important to differentiate apathy from depression. However, the treatment for depression can help. It's also very important to consult with a doctor if the patient is having symptoms of apathy. Many people are shocked to find out that up to 40% of people with Parkinson's have or develop depression. Depression may result from reaction to having a progressive disease, or it could be a physiological symptom of their Parkinson's, resulting from neurochemical changes in the brain. The importance of this distinction is that treatment will differ depending on the cause of the depression. It can be difficult to recognize depression in a person with Parkinson's, as the symptoms of advanced Parkinson's and clinical depression are very similar, as can be seen on the following chart. If you suspect that a patient is depressed, it's important to suggest that they talk to their doctor, because depression is treatable. With respect to cognitive changes in dementia, it is thought that the same process that causes the death of neurons in the substantia nigra is also responsible for related cognitive changes in Parkinson's. Slowed executive function can occur in the absence of dementia and results in slow response to questions, problems following more than one statement or thought, and sometimes difficulty carrying on a conversation. Cognitive changes can be frustrating for care partners, family, and friends who need education and support. Cognitive impairment may include a decline in short-term memory, and this becomes dementia when the person's thinking and memory interfere with activities of daily living. An important statistic is that up to 30% of people with Parkinson's may develop dementia. The difference between Alzheimer's dementia and Parkinson's dementia is that Parkinson's dementia is not a loss of memory, but is difficulty recalling memories, and when cued, the person with Parkinson's will often recall the memory. Also, Alzheimer's dementia and Parkinson's dementia occur in different areas of the brain. Alzheimer's dementia is subcortical, whereas Parkinson's dementia is cortical. A useful thing to know is that the medications for Alzheimer's dementia can be useful in treating Parkinson's dementia. It's important to recognize that sudden changes in cognition may be due to infection, and once treated, it may improve. Medications in combination with behavioral treatment are usually the most effective treatment strategy for cognitive changes. And finally, patients may benefit from a geriatric psychiatry consultation. That brings us to the end of this section on the cognitive and mood aspects of Parkinson's. Thanks for watching. This presentation has been developed by Parkinson's Society British Columbia, and should you like further information, please feel free to contact us. If you are watching this presentation in order, the next segment will cover mobility fluctuations in people with Parkinson's.